I'm going to demonstrate placement of an introducer into a disc, then the percutaneous disc decompression using a spine view and Spire device. This is a new cervical percutaneous decompression device. The procedure is done very much like discography. Of course, this patient got informed consent. We brought him in, placed him face up on the table. We've turned his head slightly. I would have an anesthesiologist at the head of the table who would not only mildly sedate the patient, but would hold the patient's head for me while I do this procedure. My prep for these cases is chlorhexidine. I drape in the usual fashion. Under regular circumstances, I might have a sterile C-arm cover on. My anesthesia would be 1% buffered lidocaine, just for a skin wheel in the anterolateral neck. In this particular case, we're going to pick the C4-5 disc and assume that it has a bulge or a contained disc herniation of around 6 millimeters that encroaches on the exiting nerve root, and the patient has pain in his arm. His MRI findings show that, and his physical exam and his history suggest that he fits the profile for a minimally invasive disc decompression. So after the patient is prepped, mildly sedated, holding still, I'll image the neck using a C-arm. Typically, this is done from an oblique angle. We place it at around 30 degrees. Head is slightly turned away from the side that you're going to enter from. So as I approach the patient, I place my hand on his anterolateral neck. The pads of my fingers will be retracting medially on the airway. The fingernail side of my fingers will be pushing the muscles and vascular structures laterally. The tips of my fingers will be feeling the anterolateral surface of the vertebral bodies. Once I place local anesthesia in the skin, I'll lay my introducer over the skin to find my target entry point. This is a 16 gauge introducer made by Spine View with a skin stop already placed on it. And as I place the needle over the skin, I have the needle tip essentially outlining the area just ventral to the oncovertebral process above the lower vertebra at this level. The area that this needle will then enter has been called the oncovertebral triangle. Approach the patient with my introducer needle, and I place it through the skin. I take a brief X-ray. The downside of this is that I'm going to have to expose my fingers to a little X-ray beam because I don't really want to lose my needle position. And once I see the needle is along its correct trajectory, I can start to advance the needle, again taking an X-ray view. And then there's a tactile sensation as I am against the annulus of the disc. And I force it through the annulus. I move a skin stop down to the skin to help hold the needle in position. Once it's through the annular fibers, the needle will be fairly rigidly held in the neck. Now that I've placed the needle and moved the camera so that I have an adjusted AP view, I can see that the needle tip, with some small adjustments, has come in anterolaterally and appears to be around 1/3 of the way across the disc margin in this view. And that would place it inside the annular margin. The annulus is thicker in the anterior and lateral aspects of the disc compared to the dorsal aspects of an annular structure. Most of the pathology, of course, is in that thinner zone on the posterior side. So coming in anterolaterally, the annular fibers create a fairly tough tactile feel. And as you pass through them, you almost feel it release into the softer nucleus. If I were to continue advancing this, this would go all the way back toward the dorsal annulus. Right on the other side of that will be the spinal canal and spinal cord. You may not feel that annulus. That's where the pathology usually is. You could have annular tears. You could have through and through tears. Some of those may have been seen on previous discograms if the patient had undergone that. So you want to stop here before you adjust the needle and do a lateral x-ray view. So in our lateral view, you can see that I am just inside, almost to the 50% mark. However, I still have my stylet in. So I remove the stylet out of the introducer. I take a syringe of saline. A cervical disc can hold up to about 1 cc, very much like the guidelines for discography. And by placing some saline within the disc, it will do two things. It will help the device slide down the introducer, and it will help liquefy the nuclear material so that it can be more easily aspirated. I then take my Inspire device and I hold it like this, with my arm partially supported by the patient's body, and I place the Inspire device inside the introducer and secure it to the introducer. I have a pillow under the neck. I have an anesthesiologist holding the head. Some people like to suggest to the patient that they hold their breath for a few minutes while they're placing needles. So now that I have the device in lateral position, I want to take an x-ray. You can see that the cutting tip is sticking out of the end of the introducer, and it's at the center of the nucleus in this lateral view. If you have any concerns, you can move it to an AP view to determine how far across you are in that dimension. Now, I've moved the camera into an AP view so that you could see the device is within the introducer. The entire system appears to stop at about the midline of the disc structure. So the cutting tip is well within the nucleus of this disc. On the top of the Inspire device, there's a slider that's orange, and as I deploy that, this cutting tip will come out about 1.5 millimeters. Now, this device has a 5 millimeter travel limiter that allows the system to then be advanced and retracted 5 millimeters. Now, of course, I'm showing this to you in an AP presentation just to give you this look that now as I advance it through the limited travel, the cutting tip will move directly into the center of the nucleus as seen on an AP view. Now, of course, this is just for instructional purposes. You really don't want to advance this unless you're in lateral position, because the devastating injury would be, of course, going through the posterior wall of the disc. So let's move to a lateral shot. So from a lateral angle, you can see that the cutting tip is within the nucleus. We're approximately 1/3 of the way across the dimension of the disc in a lateral view. As I deploy the cutting tip 1.5 millimeters with this orange slider, you'll see the tip on the x-ray advance more into the middle in this lateral view. This is the position that you'll have the x-ray, and this is a position that the cutting tip should be in when you start the motor and start to advance and retract the system within the limitations of this limiting device, which is 5 millimeters. So if you see the x-ray, you will see that when I push forward, I'm still well within the nucleus. When I retract, I'm still within the nucleus. So with the motor running, with the tip deployed, I can advance and retract back and forth as many times as I need, looking for material being pulled back into the collection chamber. That collection chamber is marked with a 1/2 and 1 cc mark. I try to get somewhere between there. When I run the motor, it could take anywhere from 15 seconds to a couple of minutes to get enough nuclear material. And we move it back and forth inside the disc, taking periodic x-rays or doing this part under live x-ray so that you can see what it's like as the device slides through its limited travel in that disc. Now we'll move back to AP and I'll show you the same maneuver on live x-ray. We'll move back and forth in the center of the nucleus. And then we look in the collection chamber and we have aspirated approximately 1/2 cc of emulsified nuclear material. Once I've collected sufficient nuclear material, I'll turn the machine off, retract the cutting tip, loosen it from the introducer, remove the device, making sure that the entire device comes out, and then remove the introducer needle, holding pressure for a moment, then placing a Band-Aid on the patient's skin, and we're done with the procedure.